Lachlan. I'm one of the liver transplant coordinators here at Kaiser Sunset. Myself and my colleague Angela Weaver are the referral coordinators. So every new referral for a transplant comes to us, and anyone who is not yet on the waiting list at a transplant center is followed by us. I do all patients with the last names A through K, and my colleague Angela does L through Z. So if you ever want to know who's taking care of a particular patient, you can look in their chart. We should pop up as providers, as coordinators, and also our phone numbers are usually in any of the notes that we have in the chart. So you can give us a call, email us, send us messages through Epic or on Teams, but feel free to reach out anytime. Today, we're going to go over some information about getting a liver transplant and what that process is like here at Kaiser. The next slide here is just what we're going to go over today, indications for a liver transplant, how liver disease progresses, and the transplant process itself. So liver disease is, the reason why patients are getting worked up for transplant. Not everyone who has liver disease is going to need a transplant, but there are lots of different causes. The more common ones that I'm sure everyone's familiar with are viruses like hepatitis C or hepatitis B. The hepatitis C used to be the number one cause for needing a liver transplant. Now hepatitis C is curable. So over time, within the next few years, really, we're going to see a very steep decrease in the number of people who are getting evaluated for transplant due to hepatitis C because it's curable now. But there are other things that are kind of taking the place of hepatitis C, and primarily it'll be NASH cirrhosis, non-alcoholic steatosis hepatitis, also known as fatty liver. So it's based on our diet, our lifestyles here in America. We just have a lot of people getting fatty deposits and needing transplant. Another really big one that is really kind of ticking up in the numbers is alcoholic cirrhosis. And that really is kind of taking the place of hepatitis C, and in much higher numbers, I think, related directly to COVID. We're going to go through some of these other issues. And, not everyone is, a person that has used alcohol or has fatty liver. There are lots of other reasons that people need a transplant. They're just way more rare. Autoimmune diseases or cryptogenic cirrhosis is where they have absolutely no idea why someone's liver has failed, but they ruled out all these other things. Also, there are medication and basically a DILI, which is drug-induced liver injury, can also lead to a transplant, sometimes in the form of accidental overdose of certain medications or supplements over the counter. Primarily what you want to think here is Tylenol. Have they gotten accidental overdoses of Tylenol, or in some cases, intentional overdoses of Tylenol? But your liver is a really important organ and you can't live without it. And in most cases, liver disease does progress and get worse over time, not better. So, your liver is very important for lots of different reasons. It's a filter. It filters out toxins. So a lot of your patients will come in with a buildup of ammonia. Ammonia is a natural waste product that our body, is going to be taking care of and releasing from our body. Usually it's filtered through the liver. When your liver's not working, though, you build up toxic levels of ammonia, and people end up in there confused, completely lethargic, sometimes needing ventilator support to protect their airway. And then also, it's got an issue that it produces bile that is helping with digestion. So you'll have digestive issues. You'll have usually gallbladder issues because that's where all the bile is stored. Most of our patients, need gallbladder stones removed, and they just are not safe candidates to have surgery. So lots of times people can show up with extreme pain from infections in the gallbladder and need liver drains for the gallbladder and bile. So you might see that pretty often. And the reason that they can't have their gallbladder removed, even though it's a very, very basic surgery, is they're too high risk. If they have, cirrhosis of any kind in the liver and have surgery, they can decompensate and very quickly go into acute liver failure and die. So no one with liver disease or cirrhosis should be having any kind of elective surgeries of any kind. Also, our liver is responsible for making glucose during times of fasting and utilizing energy for our body. So when your liver's not working, you're going to find that patients have very big swings in their blood sugars, either high or low, sometimes both. and may be more difficult to control other issues like diabetes. Um, so this picture I did take from a website and forgot to cite, so don't like use it or reproduce it anywhere. But cirrhosis is not the reason for a transplant. There are millions of people who have liver cirrhosis for various reasons, like we've talked about in the last slide, which are also listed here. But it's when your liver starts to decompensate, when you have some of these complications that we would then look into a transplant for you. Most of the time, these complications can be life-threatening. Sometimes they're just really annoying and difficult to live with, like a buildup of fluid, like ascites or edema in your feet and legs. Those are more annoying and can be treated with medications, but never will be cured without the liver being taken care of. The other ones that are way more life-threatening include hepatic encephalopathy, that buildup of ammonia that makes you very confused and lethargic, agitated. That is a issue that will lead to coma and death if not taken care of. You know, that buildup of ammonia is not something that you can let go by. And over time, you know, you may see people, frequent flyers in there with poor compliance with their lactulose. And hepatic encephalopathy long term will cause brain damage. It causes long term issues with the brain and the functioning of the brain. So really compliance with lactulose, even though it's a uncomfortable med to take because it causes diarrhea, that's the what it's supposed to do. Um, is very, very important for your long-term outcomes after transplant. You can get a transplant, but you may have, you know, severe brain issues afterwards if you are non-compliant with your lactulose. SBP, a lot of you may have seen this already. Our patients usually end up in the hospital for the first time, getting their quick evaluations for transplant with an acute infection of SBP. This is spontaneous bacterial peritonitis, and it's typically seen in people who have ascites and buildup of their fluid in their abdomen because that fluid doesn't belong there. That fluid comes from the lymphatic system. And if there's any other infection somewhere in the body, from what my understanding is that you know, it just transfers there and seeds that infection to the peritoneal area, which is a usually a sterile area of the body. So that's a really severe, life-threatening complication for anyone who has a buildup of ascites in their belly. Hepatorenal syndrome is where the failure of your liver actually starts to make your kidneys fail. Same with hepatopulmonary syndrome, where your failing liver causes your lungs to fail. That is more of a life-threatening one and a really big indication for a quick transplant. People with hepatopulmonary syndrome will qualify for extra points on the waiting list that moves them higher because their disease process is really severe and critical. Hepatohydrothorax is where instead of that fluid, the ascites going to your belly, it builds up around your lungs. So that one's a very complicated one as well and very discomforting and uncomfortable. You do need to go in and have that fluid drained so that you can breathe normally, and definitely an indication for transplant. Anyone who has cirrhosis in their liver is at risk for hepatocellular carcinoma. That's liver cancer. When your cells and tissue of the liver are not working the way that they should and they physically change and turn hard and coarse, it is something that can develop for anybody. And I've seen many, many times as a coordinator that they will convert to, you know, just decompensated cirrhosis, and now they're decompensated cirrhosis with liver cancer. It does definitely complicate things. Portal hypertension is very, very common for just about everybody with cirrhosis. Like I mentioned, you know, with cirrhosis, the tissue actually becomes, if you kind of take a look at this stage of liver disease picture here, the liver physically changes its condition. And when you get cirrhosis, there's scarring tissue. It's changed cellularly. It becomes hard and firm. And when your tissue of the liver is no longer pink, healthy, spongy, flexible material, now blood flow is trying to go through there, and there's a lot of buildup of pressure. So the pressure then backs up and will cause pressure primarily to the places that it's connected to most closely, like your stomach and your esophagus. And that's why you may also see a lot of patients in there with GI bleeds. Upper GI bleeds is, I think, a little more common than the lower GI bleeding. But upper GI bleeds can be life-threatening and can kill you quite quickly. And more than one of these will really raise your risk of mortality when it comes to your complications from liver disease. So very, very important that patients who are undergoing liver disease, a liver transplant workup, have a really up-to-date endoscopy to make sure that their varices are controlled. Most of the time, patients are put on blood pressure medications, not to control their blood pressure in most cases. Sometimes their blood pressure may actually be quite low, but it's to control the portal hypertension, especially if they have really bad varices, which a lot of our patients do. The SRTR is a really great website. It's called Scientific Registry for Transplant Recipients. I mention it over here on the right side of our page. But SRTR is all the public data available online about every transplant center nationally in the United States. The information there is abundant. There's a lot of information about every transplant center, how many people are on the list, how many people were transplanted, how many people that have been transplanted are still doing well, their wait list mortality. The Every year, technically, they put together an annual report that's very comprehensive that goes through a lot of different information, including the reason for transplant. Why did this person's liver failure occur? And in 2019 is the latest one. They don't have data or this annual report from 2020, 2021, and obviously not yet for 2022. But 2020 was when the pandemic started. A lot of people lost their jobs and found themselves at home, and maybe didn't intentionally drink excessively, but really what we have heard just had nothing better to do and drank all day. And so really, I think when we get this annual report, in 2019, it was 31% of cases of people who were on the transplant waiting list came up, as alcoholics. And I think in 2020, we're going to see a huge increase in that number to probably around 50 or 60% of the people on the waiting list now is for alcohol. So that's pretty significant. And, a reason why patients that end up in the hospital, if they have a history of alcohol use, which is pretty common, there's a lot of different things that need to be evaluated to make sure they're a good candidate still for transplant. How do you know if you need a transplant? So remember, not everyone with cirrhosis needs a transplant. It's when your liver becomes decompensated. So you'll go in and see your GI doctor, not your hepatologist, but your just general gastroenterologist. If you have some abnormal liver labs and things like that, if you start having signs of decompensation, you get referred over to our program here at Kaiser Sunset, or there's also one down in Kaiser San Diego, where a hepatologist, a liver specialist, will evaluate you, do some physical exams, imaging, some blood work, and sometimes a biopsy, but not always. Biopsies are invasive and can cause bleeding, especially for someone who has cirrhosis. But most of the time, just with a physical exam, a history, we can find out what the cause of this liver failure is and determine if you're going to need and benefit from a transplant. So liver disease comes along with a lot of other issues. We've already talked about the buildup of ammonia and changes physically to the brain because of that. Anyone who has a high bilirubin, remember your liver's a filter and filters out all kinds of different things like ammonia, but also another one is bilirubin. Bilirubin is the byproduct and waste product of red blood cells. And when red blood cells break down, it releases bilirubin, which is normally filtered out really easily and well by our livers. But when your liver's not working, it has difficulty filtering that out. So people build up their bilirubin. That's another lab that we look at to see like how bad is your liver doing. And when bilirubin is over 3 is kind of that magic number when they start turning yellow, and patients' eyes are yellow, their skin is yellow, everything turns yellow. They have a lot of changes when it comes to digestion. And they also can get those varices. You usually lose weight because ascites, that fluid buildup in your belly, will physically push on your organs so that you can take a bite of food and feel full right away. Or you can have intense pain when you take a bite of food or a drink of water because you've got no room for your stomach to expand. It's physically being pushed on by liters of fluid that don't belong there. You'll also get some issues with inflammation, bleeding, clotting, um, issues with your diabetes not being controlled and sugar swings because your liver's not filtering. There's just so many things that are affected by a liver that's failing. And so you might find these patients when they come in and they're admitted to your unit are very, very complicated and have a lot of different issues that need to be addressed, not just their liver. So if a doctor does determine that a patient needs a transplant, they usually get referred to us once they determine a few things that, they have to meet some very specific criteria for. Are they going to be a good candidate for transplant? So usually someone who has a long history of alcohol use and who's been advised many times throughout the years to stop drinking and hasn't, they need to have 6 months of sobriety. There are very few cases, and we did see quite a few of them during the pandemic, of patients who had no idea they had an issue with their liver, and very acutely ended up with liver failure and in the hospital. And this is a very, very new process, but we have a brand new process I'd say within the last year or two now, kind of developed out of COVID. But it's called the reduced sobriety pathway. Because across the board, every transplant center typically requires 6 months of sobriety, but in very rare circumstances for people who never previously were told they had liver issues, were never counseled to stop drinking or cut back on drinking, never had a DUI, never had issues like that, they may qualify for a transplant with only 3 months of sobriety. Sometimes, though, these patients come in so acutely ill that they won't make it to 3 months of sobriety. But the risk of them going back to drinking and not doing well post-transplant is pretty high. It's a very gray area of transplant, but this is one of the biggest things you might see in the hospital are patients with alcoholic cirrhosis. It's just so common. So are you a good candidate for transplant? There are a few things: 6 months of sobriety, or in very rare cases, 3. Do you have at least 2 caregivers to help you after transplant? That's a hard stop requirement. Unfortunately, not everyone has 2 people who are dedicated to helping them recover. You can also have many family members, but if no one's willing to take time off of work or, dedicate that time to drive someone to and from the transplant center, you're not going to be a candidate for transplant. You will not have a good outcome. You will not recover well from the surgery, and you will not be able to take care of it well if you don't have people to help you. So without really strong caregiver support, you're not a candidate for transplant. If you are drinking actively, you're not a candidate for transplant. If you're smoking or using marijuana, you need to stop. Kaiser's policy is that marijuana level be completely negative. It's a very gray area in transplant, so I don't really get into it with patients about which transplant centers are okay with it and which are not. Across the board, we just say you have to stop and it needs to be negative. For tobacco, same, you have to stop, it needs to be negative. Some transplant centers are okay with patients still continuing to use, but they educate them that you are at very high risk for post-transplant complications if you continue to smoke. And basically, if you die after your transplant because of tobacco-related complications to the surgery, it's not our fault. However, basically, because people are put at such high risk for complications related to nicotine and tobacco, some transplant centers will not transplant you. Some are way more strict about it than others because, if you do lose your liver for whatever reason after a transplant, the transplant center gets dinged. And if they get enough dings, they get shut down and they can't offer to transplant to anybody. So that's a big thing to kind of keep in mind, is that the reason why transplant centers are so strict is because they need to make sure you're going to do well after a transplant. You're going to take care of it. You've got people to help you take care of it. And you're committed to not only taking care of this for the rest of your life, but remaining sober the rest of your life. I forgot to mention just briefly on the left side of this page here, part of the requirements for our folks who have, even those who have 6 months of sobriety, is that they have connected with addiction medicine or with county addiction medicine if they're a Medi-Cal patient, because Medi-Cal patients don't have the benefit to use Kaiser addiction medicine program. And then AA. AA is a kind of a misnomer. AA is an actual program that patients can go through. It's kind of a community-based alcohol prevention program, but there are so many others, and we kind of just use the term AA loosely. I'm sure you guys have all seen these with patients in the hospital, in the room, Smart Recovery, Life Ring, Celebrate Life, or Celebrate Recovery. There's many, many online options for AA style programs. AA is a very religiously based program, and not everyone wants to do that kind of program. There are secular ones. The big thing, though, is that you need to be committed. You need to do at least 3 meetings a week. That's the minimum requirement. But for folks who are in the hospital who have very little sobriety time, we really encourage daily and multiple times a day meetings to really show that they're dedicated to remaining sober and being a good candidate for transplant. Um, how will you know if you're eligible? So part of the pre-transplant evaluation are all of these tests and studies off to the side. You're going to have labs that you didn't even know existed. You're going to have about 40 tubes of blood drawn just for transplant related ones. Not to mention, if patients are in the hospital, they're going to be getting daily labs as well to check their MELD score. But a lot of labs are going to be drawn. Most of the time, if patients get better and get listed for transplant, some of these tests, probably about half of them, are going to be done on an annual basis. But at least at first, this is one of our biggest complaints, having so many lab tests drawn. Usually they can all be done at one time, but if patients are especially anemic or very anemic, we have to split these up into 2 or 3 visits. Imaging studies to make sure we can rule out liver cancer. Remember, anyone with liver cirrhosis is at risk for liver cancer. And screening on a regular basis is going to be required. If someone already has liver cancer, they need to be screened more often to make sure that the cancer is not grown or spread. You can still be a candidate for liver cancer. That is one of the indications of needing a transplant. But we really just need to make sure that it meets very specific criteria for the tumor. The tumor cannot be greater than 5 centimeters. There can't be too many of them over a certain size, and they certainly cannot have spread to other organs. All of those things would disqualify you from being a candidate for transplant. If it came down to the tumor has grown, which I've seen in many patients of mine who kind of get put on hold for transplant until they can, what's called downstage. Once they can get treated, their tumor can shrink and be taken care of. Some people have very aggressive tumors that grow despite treatment and sometimes ultimately are not candidates for transplant. But suffice it to say, while getting worked up, you're going to have a lot of procedures to be done to make sure you're a good candidate. There's no cancer hidden anywhere in your body, to make sure you don't have places that can become actively infected after a transplant, like usually your teeth or gums. Make sure that you are up to date on your vaccines. Especially COVID, you are at such high risk of dying from COVID after transplant if you're not vaccinated, that a lot of transplant centers we work with have said, you're not a candidate unless you get vaccinated in some capacity. They all recommend now not only a booster, but 2 boosters for anyone over the age of 50. And I think for anyone that's immune compromised. So all of our patients meet that criteria. So two of the first vaccines and then 2 booster vaccines are really, really highly recommended by our transplant centers, and a handful say they will not consider you without it. Um, if you get better, you kind of get more stable, you get to go home, you will need to continue with transplant testing on a regular basis. You'll need to continue basically mostly annual testing, but some like the basically liver imaging is done more frequently, but everything else is pretty much done on an annual basis to make sure nothing has changed, that you're not, getting worse and worse throughout your time while waiting for a liver transplant, which can happen. And so once all your tests and studies are done here at Kaiser, Kaiser doesn't perform a liver transplant surgery. This is a very, very specialized surgical procedure, and it's only done at a handful of authorized centers called that we call COEs, or Centers of Excellence, aka transplant centers. So we contract with several different transplant centers where you can be evaluated and have this procedure completed. Um, I want to just mention before we get into requirements for transplant, we don't do this procedure here, but we do contract with centers that can do this. So a thing that's not on here basically is there will be a portion of financial responsibility that the patients are expected to meet. If you have a medical financial assistance plan here at Kaiser that does not leave Kaiser, so anyone with an MFA needs to know that they will be receiving bills for whatever their copays would have been here at Kaiser. In general, people who don't have MFAs and are not Medi-Cal patients, if they have a copay for labs or a doctor visit, hospitalizations, they will be billed the same by the transplant center. The transplant center does not know what their copays are, though. So the transplant center will bill Kaiser the full amount, and then Kaiser says, hey, this is what they're authorized for. This is their share of cost. So patients will get bills. They will come from the transplant center. It should very clearly say this is your share of cost, this is your responsibility, and don't ignore those because you are apt to being referred to claims or going into default and having different billing people kind of chase after you for things. So don't ignore bills coming your way. You do have bills that are going to come your way. The only exception are folks who have met their full deductible for the year, their maximum out-of-pocket cost, which sometimes can happen after being admitted multiple times and having various procedures done, or folks who are Medi-Cal patients. Medi-Cal patients will receive no bills for their workup, transplant, recovery, anything like that. That's all covered by the state of California. To the best of my knowledge, no one's going to pay for Medi-Cal. They're not going to pay any medication costs or anything like that. But all those things are going to be charged to patients who have regular Kaiser insurance, and it's whatever their Kaiser copay is. So most of the time, it's fairly affordable. Um, that's part of our social work evaluation. The psychosocial evaluation and assessment is to make sure that's done by our social worker, Chad. Sometimes, if he's very behind, his colleague, Shantae Stevenson, will be doing these psychosocial assessments to make sure patients have strong caregiver support. They have a safe place to go home to. If they're patients who have a history of alcohol use or abuse, that they're engaged in some kind of sobriety program, addiction medicine, AA. The expectation, by the way, I forgot to mention, is that AA continue for life after transplant. The risk of recidivism and going back to drinking is very high. I think Dr. Sahodalas quoted us like 40% of the time, people with alcoholic cirrhosis will go back to drinking after a transplant, despite years of sobriety. So that's a really unfortunate finding, and they encourage AA lifelong to prevent that. So testing and transplant requirements, we've already talked about the hard stop requirements, meaning you're sober from alcohol, and you have 6 months of sobriety, you have caregivers, and you're not using tobacco or anything else. So there are some other gray areas of transplant and reason why people will not be candidates for transplant. This is all very case by case. So some of the major reasons we list here on this page. Are you sober? Are you still using tobacco? Are you still using drugs? A thing that we find very frequently is that a patient may be sober for the last 6 months, but instead of drinking, they now use heavy doses of marijuana or have switched to smoking packs of cigarettes. So for people who have a history of alcoholic cirrhosis, you are absolutely not allowed to have tobacco of any kind. It's basically a reward system for the brain. They switched from one addictive behavior to another, so not allowed. And across the board, we don't want anyone to be doing that anyway. But have those patients with alcoholic cirrhosis started AA or addiction medicine? If they have not, they're not candidates for transplant. You can have 6 months of sobriety, but you are required to do both. Basically, that requirement only ends usually after about 2 years of sobriety. If you've got 2 solid years of sobriety, we're not going to force you to do these things, but we will very highly encourage you to connect with addiction medicine, to connect with AA, to get a sponsor, because the risk of going back to drinking after transplant is so very high. Caregivers we talked about, but the reason why this is still on here is because you can have a kind of a piecemeal caregiver plan. Maybe you've got one strong caregiver, but your backup is several different people. That may or may not be okay by the transplant center. I've had a few patients in the past historically who have no solid primary caregiver and instead like 6 friends who can provide some care on this day and this day and this day. And typically they have been declined for transplant. You have to have someone who is willing and able to take time off to dedicate to your recovery. The official requirement for caregivers is that they be available for 3 to 6 months, 24 hours a day, which is a very big thing, especially for a friend who is not related to you, who will not get FMLA or paid time off from work or job protected time off from work to take care of you to commit to. Um, Compliance is another gray zone here. Essentially, a transplant center is only going to be able to guess how you might do with taking care of your new liver after a transplant with how you're doing beforehand. If you constantly leave the hospital AMA, you're constantly in the hospital for hepatic encephalopathy because you won't take your lactulose. If you are asked continuously to go get a drug test and you don't go, or you're asked to go get labs and you don't go, or you're asked to schedule appointments and you won't, they're probably not going to list you for transplant. again, if you lose your new liver for whatever reason, but especially non-compliance or going back to drinking, the transplant center gets dinged, and enough dings will get them shut down. So they're not going to list everybody that comes their way. Typically, if they make it through our program and we endorse them, they are listed because they've met really strict requirements from the beginning. However, there are a handful of patients that still kind of make it through the door, get evaluated at a transplant center who have very questionable compliance. And it's really up to the transplant center then to decide if they're going to take on the risk of will or won't this person take care of their new liver. So enough on that. But being cancer-free is also a requirement. If you go through transplant with an infection-free right next to it, they kind of go hand in hand. If you go into transplant with active infection or an active cancer somewhere in the body, it will spread. Both of these things will spread and become almost untreatable, and very, very difficult to control either of these after a transplant. So you have to be infection free prior to getting a transplant, and you also have to be cancer free. Sometimes we do this process. I have had a patient who, I mean, multiple now, who have gotten prostate cancer discovered during this transplant workup, a couple thyroid cancers, a couple breast cancers. That is not going to disqualify you forever from a transplant. It needs to be treated and followed by a doctor and then cleared. So after a certain period of time of remaining cancer-free, you can consider transplant again. I literally just last week got a patient listed for transplant who was declined last year or 2 years ago, who had discovered thyroid cancer during his first workup. So, that's not something that's going to disqualify you forever, but definitely something that has to be addressed. You can't go into transplant with active cancer, or it's going to spread immediately and be the thing that kills you after your transplant, not your liver. Robustness is a very, very big issue right now with transplant. I think what you may have heard actually more is the frailty side. I say robustness because no one knows what frailty is. Frailty is really the overall major complex process where a patient with liver disease goes through a series of issues like building up the fluid in their belly and then the belly pushing on their stomach so they get full very quickly. They can't eat enough. They get very malnourished. When you get malnourished, your body is still requiring energy for you to live. So it starts pulling your muscle and breaking down muscle in order to do the job that it needs to do. And over time, you lose so much muscle that it becomes very difficult to do even very, very little things like get up and walk to the bathroom. And so over time, people become bedbound or become very, very deconditioned to the point where they can't walk more than a few feet without having to sit down. And these are folks that are not going to do well after transplant. After a transplant, you'll have had a very long surgery. You'll have a very large incision in your abdomen. You're going to have a tube in your throat for hours and hours. So this is something that basically it puts you at very high risk for pneumonia. And the best way to prevent pneumonia is getting up and walking and moving around. And you can't do that very easily if you're not able to walk before transplant. So frailty now more than ever is a very big issue with transplant. And if we identify patients now, we have a very comprehensive plan to identify folks for being frail pre-transplant, like during this workup process. And if you are frail, we have a very aggressive plan in place to get you stronger before transplant. Not everyone is going to be able to do that, but we really try to optimize you. And in certain circumstances, patients that get transplanted will continue to do that frailty program and the really intense rehab program to try to get stronger even after their transplant. This is something that, for most people, they go into transplant as sick as you can possibly be without dying. It's going to take a very long time to get you back to a baseline of feeling really good, being able to do things on your own, and then even longer to get back to that baseline that you probably haven't been at since you got sick, and getting back to feeling really good and going to work and doing things. It takes a long time to get back to that after getting as sick as people get when they have liver disease and liver failure. Excuse me. Active insurance is an issue that our social worker really kind of makes sure is in place. A lot of times, insurance is attached to employment. And when you have liver disease and liver failure and you're critically ill and chronically ill, you may have lost your job or you're on disability. And that really could put your insurance benefits at risk. So making sure that you've got active insurance, there's no concern about losing your job and losing your insurance. This is a very, very important concept and one that sometimes kind of gets overlooked. A lot of times people come in to the hospital in acute setting with no insurance, or their Kaiser insurance has just lapsed, or they have emergency Medi-Cal applications in place so that they can get a transplant and survive. That it does really very much complicate things because you need medication the rest of your life. You need follow-up care the rest of your life. And if you don't have active insurance, it becomes very difficult. I've only had, I think, one patient lately who has lost her job shortly after transplant, had to convert to Medi-Cal. Maybe this was prior actually to January because she ended up having to be followed exclusively by the transplant center with her Medi-Cal only benefits. Now, as of January 1st, Kaiser will follow Medi-Cal only patients. Prior to that, if someone was getting worked up for transplant and had Medi-Cal only, once they got listed for transplant, they had to disenroll from Kaiser. So thank goodness Dr. Sahota was like a champion of this program, which took years to get in place. But now our Medi-Cal only patients can continue being followed by Kaiser as well as a transplant center. So it's very, very helpful for these patients who previously had to kind of get a whole new medical team because they had to be disenrolled from Kaiser for transplant. And then medical comorbidities kind of goes along with cancer-free, infection-free. There's lots of other things that people usually come into transplant with. Severe obesity is one of them. That's one of those causes of non-alcoholic steatosis hepatitis is, yeah, you don't drink alcohol, but you only eat fast food. Your liver is full. Your BMI is 50. It's going to be extremely difficult for these folks to recover from a transplant surgery and for their incision to heal. Again, it's a large incision. It goes basically from your breastbone down to your belly button and then down to both hips. It's going to look like a Mercedes symbol or a peace sign. Very large incision, and adipose tissue, fat tissue, is not very vascular. So there's going to be a lot of wound issues and healing issues for people who are morbidly obese. Also coming into transplant with uncontrolled blood sugars or uncontrolled blood pressures is a big issue because these are issues that will cause kidney problems. So you may go into transplant needing just a liver and come out now needing a kidney transplant. So also another big thing about diabetes control is compliance. And if your blood sugars are completely uncontrolled now, the transplant center is going to assume you don't follow the diet you've been asked to follow, you don't take the medications you've been asked to follow, and they will not transplant you with an A1C above a certain number. Some transplant centers are very, very strict, and your A1C needs to be less than 7, which is still high. But some transplant centers cap that at 9 and say if it's above 9, you absolutely are not compliant in any kind of way with your diet or medications, and we're not going to transplant you till this number is much lower. So medical comorbidities really is there's a large thing, a large number of things that this could be the umbrella that falls under here. So I would say that it really just is kind of case by case. Medical comorbidities also include past history of cancers, multiple abdominal surgeries, issues with the lungs like emphysema, lung disease, heart disease. So all of these things could be reasons that you'd be declined for transplant. But in general, I think they're very forgiving for a lot of issues. And as long as you're being managed in most cases, and doing well with those issues, you're still going to be a candidate for transplant. But again, very much case by case. And sometimes it's a bigger picture issue, like coming in with severe liver failure, but you also have this very long history of things that have already been difficult to control that may rule you out as a candidate for transplant, unfortunately. So again, case by case, and in most cases, usually determined by the transplant center. Kaiser wants to give everyone the chance. And as a Kaiser member, you have the right to be evaluated at a transplant center, despite maybe not being the best candidate. And we kind of, in those cases, sometimes leave that up to the transplant center to decide, are these patients able to have this transplant and recover well from one? So once they get over to a transplant center and get evaluated, for those people who are in the hospital, most of the time we do a very quick evaluation or as quick as we can, and get them over to a transplant center via bed-to-bed transfer. So we'll take them from Kaiser over to a transplant center locally, or sometimes even out in Arizona, depending on their score and how long it might take them to come up for transplant. But we usually do a bed-to-bed transfer, a quick evaluation, and then listing. Once someone is listed, the thing that they really, really need to know as a patient and, for medical staff in the hospital, knowing what their MELD score is a really good idea. So MELD is not a lab. MELD is a calculation based off of lab. So MELD is an acronym that stands for Model for End Stage Liver Disease. The way that organ allocation works for liver transplant in the United States is whoever's the sickest is going to be the highest person on the waiting list. So the way that they determine who's the sickest and who's going to be the highest on the list is with this MELD score. So MELD is a calculation. So I know people kind of, especially my patients, kind of go, what is a MELD lab? I don't see that one being drawn. It's a calculation. So I often not only use the Kaiser portal, in our Epic system, it gives you a MELD score. If you click synopsis and click liver, it will say MELD score. So you can also go to a tab called Aura, AURA, and that will also give you the MELD score and their mortality prediction based off of the MELD score. So that's a very interesting one to look at. I often kind of double check it with the a website OPTN MELD score. I just Google OPTN MELD score. OPTN is Organ Procurement Transplant Network. So that's the official MELD score calculator that when someone's getting listed for transplant, they use this calculator. It's embedded into the UNOS website when someone's being listed for transplant. So MELD is a calculation based off of creatinine, INR, T-bili, and sodium. So you need those 4 labs. Also, albumin in most cases. To list someone, you have to have an updated albumin level along with those other labs, and their birthday. So those labs and the birthday, put those into OPTN, and they give you a MELD score. So MELD is kind of like a spectrum. So you have the low end of things, the high end of things. The lowest the MELD score can go, possibly for people who have really good liver function, your MELD score is going to be 6. 6 is the lowest it can go. 40 is the absolute highest it can go on the wait list. But native MELD could be much higher than that. I just transferred a patient on Monday whose MELD score was 43. So your score can be higher, you can be sicker, but it caps out at 40. I currently have a patient in the hospital with a MELD of 35. It's very concerning. These scores are very, very high, and the higher your score is, the higher your chances of dying of liver disease are, and your need for liver transplant is much higher. So the reason why it's very important to know this MELD score is because it really kind of depends on which transplant center they're going to. Here in California, we contract with 4 transplant centers. Scripps Green in La Jolla. That's probably not one you're going to have a patient listed at. And then the others are Cedars-Sinai, which we don't often use, just it's very difficult to get there. And then UCLA and Keck USC. So those 4 transplant centers, the average score at the time of transplant is right now 35. This number changes every 6 months when UNOS goes through and reevaluates every transplant that's happened nationally, and how many people have been transplanted and what their score was at the time of transplant. So they go through, and currently, right now, the average score in California is 35. If you can leave California and go out of state, say you've got a patient who's listed already in Mayo Clinic in Arizona, the average score at the time of transplant there currently is 26. The reason why it's very important to know the MELD score and the listing status of your patients is because if a patient's not yet listed for transplant, and their score is, say, 25, 26, they're sick in the hospital doing an expedited workup, that's still not sick enough to come up for transplant here in California. So say they're a Medi-Cal patient and they need to stay in the state of California, they'll be transferred to Keck USC or UCLA to do an expedited workup, but they likely won't come up for transplant anytime soon. So they would go over, get evaluated, maybe potentially get listed, and then get sent back to Kaiser while they wait for organ offers or while they wait to get better and go home. But if my patients don't have Medi-Cal and they are interested in leaving California, it's very important to have that conversation with them about their going out of state and travel benefits. So in general, Kaiser has a really, really good comprehensive benefit plan when it comes to needing to go out of state for various medical issues like transplant. Really, I've worked at a transplant center. There were insurance companies I worked with that would try to deny transplant completely and say, it's not needed. So not only Kaiser is saying it's needed, we're going to pay for it, and we're going to pay for you to go to a place where you can get it done sooner. Being a chronically ill patient with liver failure costs insurance companies a lot of money. You're talking hospitalizations, blood transfusions, nursing stays, medications. It's a very expensive disease to have, and transplant, although very expensive in the long run, stops a lot of that chronic, frequent hospital admissions. So going out of state for transplant is so highly recommended because there's so many people here listed in California for transplant that our waitlist mortality is very high. I mention waitlist mortality here because I do often bring it up with my patients to say that just because you need a liver transplant does not mean you're going to get one. Just because you get listed for transplant does not mean you're going to get one. Your chances of getting one are much higher, though, if you can leave California and go to a state with also a less population and less people listed, less competition, and they transplant people at lower MELD scores. So again, here in California, your score has to be right around 35, maybe a little bit less depending on your blood type, maybe a little bit more if you've got an O blood type. Um, but if you can leave and go to Arizona, the average score at the time of transplant there is 26. And lately, the last couple of weeks, every transplant that has come out of there, which has been many, they've all had the same MELD score of 26. So a person here with a MELD score of 30 in our hospital who is sick still may not come up for transplant offers here in California for some time. So that's really unfortunate. So if they can go out of state, we do not only pay for it, but we pay for their hotel. We pay for their family member to come out there. We will pay for their gas. We do want them to drive because they may potentially be out there for some time. So if they can drive, we reimburse their gas 56 cents a mile. We pay for the hotel for every day that they're out of state. And then also every day that they're out of state, we give them a small stipend, like a small allowance called a per diem of $50 a day for the patient as long as they're out of the hospital. They won't get that if they're in the hospital. And also for their caregiver. The caregiver is required to be out there even if the patient's in the hospital. So it does become a big burden on the caregivers in some sense. You're still required to have two caregivers, but only one has to go out to Arizona with you. So it really does put a lot of burden on that one caregiver to be the sole person taking care of you for your transplant recovery. But it is very, very, very highly recommended to go out of state if you can. A lot of times, our folks who are in the hospital may not need to consider that. I have a few right now in the hospital who are very, very sick and are very competitive, even here in California. Um, Donors are a little bit different. So there are two options for our patients for donors. That's living donors and deceased donors. People who are sick enough to be doing an urgent inpatient transplant evaluation here at Kaiser usually don't need a living donor. Usually they are, in most cases, sick enough to come up for offers for transplant. But living donors, if they are interested and someone is willing to donate, it's going to be a piece of their liver, usually a large piece, about 40% of their liver will be donated. The only transplant center we contract with for this is Keck USC. So USC does so many number of donor transplants that they have really good outcomes. We use only them right now. So that's something that they need to know. If they have a donor, it's going to be a large portion of their liver. The donor has to be in really relatively good physical condition to make sure they're not going to have issues down the line post-transplant. So that's all decided by the transplant center. A donor will only be evaluated once a person is listed over there for transplant. Most of the time, though, however, the criteria to be a donor, a living donor, is very, very strict. And even though someone may come into this process with 5 or 6 people willing to donate, none of them end up being able to donate because the criteria is pretty strict. Specifically, weight criteria, you can't have a BMI more than 35. You've got to have the same blood type, roughly kind of the same body habitus and size. So there are lots of specific criteria. And even if you meet all those criteria, once you do the imaging, there may be some anatomical issue that rules you out from being a donor, or there may be something you say to the psychiatrist that gets you declined as a donor. Maybe your motives are not what they need to be. It's very much an altruistic gift. You can't expect any kind of payback or gift monetarily or even non-monetarily, but there has to be zero expectations of any kind of reimbursement for your organ. So that's waiting for a liver transplant. Waiting for a liver transplant, no one can tell you how long you're going to wait for someone to die and pass away and to donate an organ to you. It's all dependent on how sick you are. And even if you're very, very sick, you still may wait a while till they find the right one. Unfortunately, if you're on the very, very short side of things or on the very tall side of things, it does make it more complicated to find you a deceased donor. Your donor kind of needs to be roughly the same size, otherwise there'll be a big mismatch in the vessel size. So your donor's liver needs to match up to where your old liver was, and when there's a big discrepancy, we can get a lot of issues with strictures and narrowing of the blood flow through that vein and vessel there. So the wait times, it's I can't really think of the word right now. It's kind of TBD. It's basically based on how sick you are and organ availability. That's a really hard thing to tell someone because you could be very stable for a long time and wait years and years and years, or you could get listed with a score of 20 and the next week get SVP and your score is now 35, and that's your window for transplant opportunity. So once you do get the transplant, this is going to happen at the transplant center. The list is run by the transplant center. So Kaiser has nothing to do with transplant offers, transplant surgery, or transplant recovery. We are notified certainly right away. We're kind of like the third party middleman at that point. But the surgery entirely happens at the transplant center. You're called in by the transplant center. Essentially, what you could tell patients who are listed for transplant or who are about to be listed is really make sure your phone and your caregiver's phone are on at all times. If your patient has encephalopathy, this comes down to their their caregiver being available 24/7, having their phone on even at nighttime, because these calls can come in 24 hours a day, holidays, weekends, 2 in the morning. It happens all the time. So the surgical procedure is the same no matter what transplant center you go to. This is a very, very specialized surgery. Transplant's a very small world. Usually all of the transplant surgeons at transplant centers know each other, meet each other at conferences. So even Dr. Sahota knows a lot of these transplant surgeons from these various conferences. I used to go to the kidney one. I'd see the same people over and over and over again. So this is a surgical procedure. It's the same surgical procedure. You just have a different transplant team based on where you go. I don't get into the transplant surgical procedure. Really, I don't know a whole lot about it. I used to work in the post-transplant ICU at Cedars-Sinai. I'd get fresh surgical patients, but it doesn't mean I know what the surgery is. So this conversation, I usually leave to the surgeon at the transplant center. But I do usually just tell people this is a very long surgical procedure. You'll likely be in there anywhere from 9 to like 15, 16 hours on the table. Because it's such a long and lengthy surgery, 99% of the time people go to the ICU for their recovery for at least 24 hours. What you're going to find is that blood sugars right away are very difficult to control. So most of these folks come out on an insulin drip, and insulin drips need to be managed in an ICU setting because they do hourly blood sugar checks and titrations of that drip. There likely would be other drips as well, blood and transfusions and things like that. At Cedars, I don't know if this number is accurate or not, but I really clearly remember most of my patients coming out of a transplant surgery having received 50, 60, or 70 units of blood and platelets and cryoprecipitate and products throughout their surgery. And those massive transfusions of blood products can lead to more complications. So I think that's another reason why they all came out to the ICU setting. After your ICU stay, you'll be downgraded to a different unit in the hospital, like 4 North, and like 4 North has the transplant center. But that's where our very, very dedicated people who are really informed about transplant surgery and recovery are going to be managing these patients for another week or so, depending on how everything goes. But usually about a week in the hospital is very, very normal. On the outliers can be much longer. Also, my outliers, I had a patient who went to USC for a living donor, was going to the gym every day beforehand. She was out after 3 days. So that's a lot more rare, but a week is on average. Your recovery from post-transplant, though, before they let you go home, you have to be able to manage your pain with pills. You can't go home on IV medication. So your pain is going to be managed, your liver function is going to be looking good, you're not bleeding, they'll let you go home. You're not going to be home very long before you come back to meet the team in the post-transplant clinic for post-transplant care. The transplant centers are going to be responsible for post-transplant care for a certain period of time. Here in Los Angeles, UCLA monitors people for 90 days after they get out of the hospital, and Keck USC follows them for 45 days when they get out of the hospital. I believe Cedars, I haven't used Cedars in a very long time for any of my patients, but I believe they're also 45 days from the hospital discharge to when they let you come back to Kaiser. Arizona is a little bit different. Arizona is our main out-of-state transplant center. They keep patients for 1 month after they get out of the hospital. As long as everything's going well, the liver numbers look good, there's no ongoing issues that need to be addressed, they let you come home after 30 days. The things that patients can expect, though, in the immediate post-transplant phase, as well as long-term, are medication side effects and, really all these things listed here. So we're going to go down each one of them. Transplant is not only a big commitment to taking meds every day for the rest of your life, but also knowing that ongoing care may be required the rest of your life. You may not have a good outcome. Most people do, but some people need way longer follow-up for other issues. So transplant cannot be thought of like a hernia surgery. You're not going to go into a surgery with a problem, have it fixed, and come out perfect. You're going to go into surgery with a big issue, your liver not working, and you're going to get a new liver, but you're going to come out with a lot of new issues. And a lot of these new issues are listed here. Medication side effects, the one I like to kind of highlight the most for people who already have diabetes or who are pre-diabetic or maybe diet controlled diabetics, is that high dose steroids are going to cause a lot of issues with your blood sugars. It's going to be very, very difficult to control your blood sugars for a very long period of time. And even after you stop the high dose steroids a few months after your transplant, the effects of the high dose steroids could last a lot longer. So it's important to note that the high blood sugars could be an issue ongoing for the rest of your life. If you don't have diabetes to start with, we could end up giving you diabetes because of the transplant and the med you're going to be on. The other big thing to kind of mention, as not really a medication side effect, but really the medication intention, is that your new liver is not going to work on its own. Your immune system is always, always, always going to try to fight and attack that new liver. And, the only way we can prevent that process, which is rejection, that's where your immune system attacks the new liver, is with putting you on medication that kind of turns off very key components of your immune system. And so if your immune system is suppressed for a very good reason, for preventing a rejection of your new liver, you're going to be at high risk for infection. So infection prevention is going to be something you have to practice the rest of your life. The best and easiest way to prevent infections is to stay away from sick people. Also to use hand sanitizer, wash your hands. If you're going anywhere in public, anything that's kind of a common use area, elevator buttons, handrails, you need to use hand sanitizer. Your biggest vectors for infection are your eyes, your nose, your mouth. And if you've got dirty hands and you're touching those things, you can very easily get infections. Obviously, another big place of infection is the surgical incision. The risk of infection there really is minimized after a few weeks after transplant when that's a totally healed area. But for sure, immediately after transplant, if you're touching that incision or you're dressing with dirty hands, yes, you will probably get an infection. So infection prevention and really just keeping your hands clean, your home clean. I remember at Cedars-Sinai, we had a patient who was constantly on hold for transplant because he lived in a very uh, really unsafe place. He had a lawsuit against his landlord. There was mold in the walls, there was cockroaches on the floor. Like that's a place that this person will not be safe after transplant when you're at very high risk for infection. So that's a big thing to kind of keep in mind is that, an ounce of prevention is worth a pound of cure. So really, really just trying to prevent infections because we can certainly help when you get an infection, but it's best to try to prevent those to begin with. About 30% of people who take one of the medications that they're going to be on lifelong, Prograf, will get skin cancer. So it's very important to know that if you already have a history of skin cancer or a very big family history of skin cancer, maybe not personally yet, you're at much higher risk. You are almost one of those people guaranteed to get transplant, post-transplant skin cancer related to their medications. So very, very important to know that within a year of your transplant, you'll be referred to dermatology, and we request that you see them every year for annual skin checks. And certainly between those times, you should still be kind of taking a look out for skin cancer. The most common areas of skin cancer are those places most exposed to the sun, like your forearms, the tops of the head for people who don't have a lot of hair up there, forehead, nose, and the places you may have been burned often as a child. I've got a long family history of skin cancer and a long history of personal burns as a child. I'm at very high risk for this. If I was to be put on Prograf, I probably would get skin cancer. So just very important to know that, they have to be on the lookout. Again, prevention is worth an ounce of cure here. There's horror stories of our patients just kind of ignoring different lesions, not really knowing what they're looking for, and losing chunks of their nose or chunks of their cheek. So very, very important to just kind of note this is a really easy thing to look out for and prevent and take care of if it happens. Other cancers that can happen are way more rare, but there could be recurrence of liver cancer, and obviously recurrence of disease. NASH cirrhosis could come right back to someone who doesn't change their lifestyle and their diet. But another cancer that could happen, more rare, but definitely related to the medications for their transplant, is called PTLD, which is post-transplant proliferative disease, a very rare cancer that's very aggressive and usually lethal. So that's a kind of a rare one again, but always very, very sad to see. Oh, here, recurrent liver disease. I had that slide already, or on my slide already, but that's definitely something that could happen. In most cases, if you take really good care of your liver, it's going to last you the rest of your life, depending on how old you are. Most of our patients are a little bit on the older side, in their 50s, 60s, sometimes 70s, but their recurrent, native disease can come back to their liver. So that's kind of an important thing to note, is that this is not a guarantee that you're going to have lifelong good liver function. Compliance is very important with taking those meds every day, not going into rejection, preventing infections that could cause rejection, and really just kind of taking very good care of yourself going forward, not getting skin cancers and limiting your sun exposure after a transplant. So all these things are super, super important. And, I have seen several patients, a handful of patients come back 30 years after their transplant, and now their liver is starting to get some of the old, cirrhotic issues, or at least fibrotic issues, and they might need a new transplant 30 years from the last one. So they did a really excellent job of taking care of their livers for a very long time. And then really they have to know and understand that lifelong follow-up is going to be a requirement. They'll be followed by the transplant center for a certain period of time, returned here to Kaiser. They'll be very close follow-up for usually about a year, and sometimes much longer. But really regular labs at least are going to be going forward. It just takes a long time to get to that point where you follow up once a year with your liver doctor, but for forever, you're going to be following up in some capacity with our team. So usually at this point, I do have some questions, and people want some more elaboration on things like our policy for travel, or various reasons for decline and denial. But suffice it to say, you've got a team of people here at Kaiser that are going to be working with you throughout this process during the referral, waitlist, and post-transplant phases. You can always feel free to reach out to our team, whether that's through phone call, or a Teams call, a Teams message, a staff message. We are always here to answer questions. And also, we also have a 24-hour line available for our post-transplant patients. So if you have a post-transplant patient who is having complications, is frequently in the hospital, advise them to call our liver transplant office. Even after hours or on the weekends, we always have someone on call. That happens to be me this week, so maybe don't tell anyone right now. Just kidding. But no, in general, there's always someone to answer any questions, night or day. So that number, just FYI, is 323-783-1. They're bothering me. And if they call that number during the day, it's going to give a list of all of our coordinators, and you press, the option to speak with them. I'm option 6 on the phone tree. Nina, who takes over for my waitlist patients after me, is number 3. So all of us are available. If you don't know who the coordinator is, you can press our TAs, Galvin or Janelle. And then after hours, it's going to be a different recording that says, hey, our office is closed. If you need to speak to someone, I think you press 1. Operator, and you just ask for the on-call coordinator. So that concludes my presentation today. If there are any additional questions, please feel free to reach out at any time. Thank you.